Morning, everyone. Thank you for coming to today's meeting. I think we'll start because there's quite a bit to get through. So the first thing before the formal meeting starts is that, as usual, non-exec directors and directors have been walking around various parts of the hospital to do the 15 Steps Challenge. So I'd just like to get some brief feedback from everybody on that. It's always very interesting, very useful. So let's start today with Elizabeth, who I went to C3, did you, Elizabeth?
Yes, visited C3, Lawrence, which is the acute stroke unit. One of the first things that you realise is that the physical environment is not ideal. There is a small gym rehab room, but talking to the physiotherapists, it's just not big enough. By the time you get a patient in there with the lift that they need and that kind of thing, it's very, very cramped. One of the other challenges that they talked to us about is that this is the ward that people come to when they have been on the St George's HASU, hyperacute stroke unit. They come to us. And when St George's say that a patient is ready to be transferred, they have to be transferred to us within 24 hours. And actually finding the space and having enough beds to put those people in is very, very challenging. So that was another thing that came through. Peter and I watched the huddle, and he can talk a little bit about that. Charlotte, the boards weren't up to date. Okay, very briefly, Peter.
So the huddle was sort of underway during our brief visit, so that was clearly very well attended from a multidisciplinary perspectives. That was really good to see. I know Mahita's working on getting the process more slick, and the new tools the electronic whiteboards will help with that, so that's really positive. The feedback I got from some of the patients I spoke to was unanimously positive about the care being received from our staff, which is fantastic. The only one comment from one of the patients who's towards their end of their recovery is car parking, how difficult it is to park, and the price it is for people who come for a lot of times over a very sustained period. So I know Trevor will be keen to pick that up.
Thanks very much. Let's move on to Pat.
Yes, I visited C1, which is just over the way, with Craig and Charlotte and our new COO, Dan, who's there. This is an area which is still under construction, but is already looking very much better than it did before. It's ambulatory care with maternity phlebotomy and medical infusion patients. So they are essentially outpatients. They may be there for an hour or so, but it's an outpatient area, and it's, as I say, still under construction, so it smells of paint. But it's very nice and clean and bright, and I think the staff are managing as well as you could expect under the circumstances of people going back and forth with buckets and drills. The patients who I spoke to there, who are regulars, can see that it is going to be very much better than what they've experienced before, and there are some good, more private areas for procedures, which will be, I think, welcome as well, given that they were done in a more open area before. The area of concern was that there is also, along a corridor outside SAU, a 4-bed escalation area, which is really not a nice place to spend any time. And there was a patient who had almost certainly been there too long if he needed to be there at all. It's a sign of the pressure on the hospital for beds, and the patients are tolerant, but it's not a place to be. The beds are too close together. There's no room for a side table even, and it's just not to spend 4 or 5 days in there would be very unpleasant. Outside there was a trolley that was not chained to the wall, but that was because there wasn't a socket for the computer on the side of the wall where you could more easily have chained it. These are all the sorts of things that I know that Trevor's team are battling with, and also just the pressure of beds that we've got already before we go into winter. But I think those patients, and I think Charlotte's already started to address the problems of the specific patients who are in there.
Thanks very much. Clearly one or two things to attend to there. Aruna.
Elderly, sorry, thank you. A6 is an elderly care ward, female elderly care ward. It was very clean, very welcoming. The ladies in the ward seemed very happy. The staff seemed very motivated. I think Army runs a very good shift and very good team. We got very, very good feedback from the patients and relatives. The consultant there is away on sick leave, I believe, but I understand that the cover that's been arranged is very effective. Hand hygiene, I think 90+% is what Army said. So those are all the really good things. Things to improve. Pressure ulcers, I think by definition, given it's an elderly care ward, I think they could do with more better pressure mattresses. Falls, again, you would expect that in an elderly care ward. I think the one thing to say is the ward is sort of L-shaped. One part of the ward is very, very kind of open and easy to sort of manage. There are other 4-bed units in the ward that are sort of along the L, which are perhaps more difficult to manage. But again, I think Army's view is better staffing, but I think that's a problem throughout, would help with the falls. More attention would sort of help with the falls. Infection control, that again is an issue, but I guess again the way to combat that one would be more isolation rooms. They have 2 isolation rooms. We could probably do with more, but I think that's a hospital-wide problem. I don't know if Ruth, you wanted to add anything else?
Just 2 quick points. I think a huge well done to the team, because the boards were completely up to date, which was fantastic. Both the boards with staffing information and also your photo boards. That was fantastic to see. And I spent some time talking to the husband of an elderly lady on the ward who had previously been on the ward 14 years ago and had a very bad experience. And in the small hours of Tuesday morning, he said, was concerned when he knew his wife was going to A6. But he said the care since Monday across A&E and the ward has been absolutely faultless, and that the changes he can see, not in the physical infrastructure, but in how the ward is run, is quite astonishing. So I think hugely positive feedback there for the A6 team.
Thank you very much, Ruth. Let's move on to Ian and Rakesh, who went to theatres.
Right, so we went to the main operating theatre suite. Was shown round by a Band 7 sister who had been working in the unit for 42 years, which I thought was impressive. And that reflected, they've got a very stable workforce there, and people seem to have managed to progress internally. So she said there were a couple of vacancies, but there were potential strong candidates internally that could move up into them. So morale seemed to be very good. Went to the huddle, which seemed to be functioning well. It was exclusively the nursing staff in the huddle. There wasn't anyone else there, so there were no medical staff involved in the huddle. I asked if there was one thing they could change, what would it be, and it was relatively trivial. It was that they have an old-fashioned whiteboard writing on it with marker pens, and they'd like an electronic whiteboard, please. And they've got the screen there, but it's not been activated to use it. So that seemed like a relatively minor issue to change. I think that the striking thing was the physical space, and when we approached the corridor coming to theatres, The surgical wards are reasonably co-located, intensive care unit is reasonably co-located, but the corridor linking theatres to the surgical wards had large rubbish caddies and beds in it. So a long corridor where if two beds were approaching each other, they couldn't pass. So that wasn't good. And then inside the theatre suite, the physical space is pretty cramped. Recovery is small, and in the theatre suite itself, the internal corridor is cluttered with stuff that they need to have there. There's nowhere else to put it, so that the built environment doesn't look appropriate for what they're trying to deliver. So that the people stuff is all good, the physical space less so. And surgical admissions unit, one of the issues in the morning was 2 patients who were waiting to have confirmed beds before they could have their operating theatre slot confirmed. And that was actually confirmed during the huddle when was there. But clearly people working to try and move things. Getting patients moved to theatre portering seemed to work well.
Thank you.
Rakesh?
Thanks very much, Ian. That's very interesting. Thank you. So let's move on to Richard and Lisa. Thank you.
Shall I kick off, Lisa? Yeah. So Lisa and I went to maternity with Emily. And I think there's a common theme beginning to emerge in this, because one of the observations that I made, particularly on entry at the ground floor reception, is it's not a terribly inviting environment. I mean, there's physically there's not a lot that can be done to change it, but it's just not a terribly inviting environment. I thought that the sort of the staff atmosphere that I observed anyway was strongly collegiate, very positive, and I just got a strong sense that there was good teamwork within all aspects of the maternity ward there. I think one observation that did concern us was security, because whilst there are the self-locking doors, they are by no means foolproof in any way. There's very little security on the entrance at the ground level, and at each of the ward entrances, I mean, there's plenty of opportunity for people to flow in and out without really being properly checked or detected. So I think that was a concern. But otherwise, as I say, I came away with very sort of positive view of the. It's a very calm, pleasant environment. It wasn't busy, but that probably makes a difference as well. But it was a good trip.
Thank you very much, Richard. Lisa, do you want to add?
If you don't mind, Chair, I took a chance to talk to some community midwives, and what was interesting talking to them was the growing workload that they are seeing and experiencing, and that is because a lot of they're seeing a growth in the number of women who are choosing not to give birth here but then come back, and they are our patients. So some of them were saying they're seeing a considerable increase in workload, and when I asked them, because they know these women really well, why women were choosing to go elsewhere, the main issue that, and it wasn't just one, it was a number of them, was a lot to do with the environment that we actually offer here, and they were choosing to give birth elsewhere, although they were really pleased with the care because they fill in our friends and family test forms. They're really happy with their antenatal care, but they're not. So it's putting an extra workload on these women, and it is not what the staff were telling me was that they don't feel it's good care because they're not able to give continuity of care. So I thought that was a really interesting point that they raised with me.
Thank you, Lisa. That's very interesting. Next is James and Trevor, who went to critical care.
I'll start. I'm sure Trevor will talk about the challenges from an estate's perspective, but the overwhelming impression when you go onto our critical care facility is a kind definition is the quirky layout that we have. It is cluttered. It's an L-shaped ward. One has to pass along a lot of clutter, which is needed. It's essential equipment to look after patients who are by definition very sick. and the staff there are working in a very constrained environment. There is building work, as you know, in B block. A number of the staff were saying it is loud. They haven't had any complaints from patients or relatives, but the staff are very aware that it's loud. The overall impression in the bed space area, there's a striking contrast to what I experience when I go to other hospitals. I was doing a ward round at another hospital yesterday, and it's quite a long walk between beds, in bed spaces, in critical care facilities, in other hospitals. There are nurses there with electronic stations filling out data, and there's lots of equipment, but a sense of space and tranquility, surprisingly enough, on intensive care units in other hospitals. But that is clearly not the case in our intensive care facility. The nurses are almost sort of going bottom to bottom as they're going past each other to get past bed spaces, and when patients are receiving ventilation or dialysis, there's a lot of equipment around the bed, and the side rooms are incredibly cramped. There was a busy ward round going on. There were 2 consultants, lots of junior doctors, physiotherapists, the lead nurse, and they go from bed station to bed station. I did talk to a number of nurses in different bed spaces, and they felt that the ward rounds were very inclusive. They felt that there was a really good sense of team working on the unit. And the second consultant was going to peel off the ward round in order to go down to our acute medical unit to see what help could be offered to identify sick patients who might benefit from critical care support. So it felt like the interface between critical care and the wards was improving. I spoke to some relatives who were waiting in the waiting area. They were clearly quite distressed. Their relative was unfortunately very ill, but they were full of praise for the care that they were receiving, and they felt that the communication was excellent. I'll pass over to Trevor, who might spend a little bit more time talking about the layout and environment.
Thanks, James. So I think it was a really useful visit for myself. My team are working out of the new HDU facility that will come into this space over the next sort of 6 to 9 months. So really helpful for me to again just have that visual look at what the impacts are of that space and that environment and learn. And it's good to hear actually that the estates team are working very closely with the clinical lead and the clinical teams about designing that and co-designing. So I've got a lot of positive message about that. There's a lot of involvement in that co-design. I think obviously it's challenging that we are doing B and C blocks in terms of external refurbishment. I was amazed the amount of every single window in that area had scaffolding that you could view, and I think there's some work that we haven't done around putting privacy blinds up in certain areas that need some work on it that we need to go back and do. So we can, so if patients want the privacy, they can do that. The other challenge is that actually people can't open the windows because it's dusty as well, and I think we have to work around some of the comfort cooling issues that we might need on that. I think, as James said, it's just extremely cluttered. You know, we went into sometimes there's wardable patients and they have a need for the toilet facilities. We've got the hoists in the toilet and shower facility that has to be moved out if you want to use the shower, and it's just very, very cluttered in terms of every single room. Even their beverage space was small. The relative space is small. So I think we've got the message clearly, and it's about. I'm hoping this one we can resolve by the new HDU unit.
Thank you, Trevor. Finally, Kevin, who went to B5.
Yeah, I went to B5, which is a surgical area. I went with Nikki Watkins, who's at the back there. And the reason I'm pointing her out is because I'm going to embarrass her, that one of the things that struck me first of all was how well Nikki interacted with the staff and knew their names and was engaging with them and chatting with them, and they all knew her. And I think that was really excellent to see, that relationship between Nikki and the team. There was a problem with the battery on the hand gel outside of the ward, but there were 2 other hand gels that were full, so it was there. But the ward clerk had sort of identified that she thought it was a problem with the battery because she'd filled it up, so that was positive, and there was other gel there, so that was good. The photo boards were out of date, but I know Lisa's got a plan for that. It was quite cluttered. There was quite a lot of activity happening because they were clearing away breakfast, but it was narrow corridors and things like that people have mentioned already. I also attended the huddle, and it was really strong interaction between the nursing team and the therapy team, and the therapy team had really got into the electronic tool and were updating that. But again, the absence of the medical team who dipped in and out more is something that I know they're trying to solve, but about synchronising the different ward rounds and activities that are going on for the different teams is something we need to fix. There was one patient that had been in over 100 days, and sort of common problem about getting them out to a nursing home, and the difficulties that meant that actually they were dipping in and out of being medically fit, but because they were staying in, they were then picking up infections, and so again, it's an area to address, and I took the actual name of that patient to see what we can do to try and escalate that, because that was a real problem, but the ward team were doing everything they could. Again, I think the electronic whiteboard exposed where information is not necessarily being kept up to date, and we can see that now because it's on the board, and so that was highlighting some areas to pick up as well. But on the whole, the team were very good working together, the people that I saw.
Thank you very much, Kevin. Thank you very much, everybody. Clear theme coming through all of that, wasn't there? That our people are great and they're really good teams and they work very hard and the patients like them, but the buildings, the facilities are old and crowded, and clearly we'll be discussing some of the options to deal with that later on. Right, let's now start the formal board meeting. So first of all, welcome. Are there any apologies?
There are no apologies.
No apologies, thank you. Are there any new declarations of interest from last time? No, thank you very much. Let's very quickly then run through the minutes of the previous meeting held on Friday the 13th of October. I'll just go through the pages, and if there's any comments on page 1, page 2, page 3, page 4, page 5, page 6, and the questions. Good, thank you. There is a small, I think, action log this time. 3 items, 2 scheduled for the next board meeting and 1 for the January board meeting. So we'll leave those until then. Right. We're now. Aruna. Oh yes, Aruna and Dan. Yes, I ought to be. Sorry, I'm forgetting my manners. I'd like to welcome Dan Bradbury. He's the new Chief Operating Officer who replaces Caroline, who left last month to go to work in a hospital much nearer to where she lives. Dan comes to us from Southampton and spent his. He's been in the health service a few years, but spent his previous career in the army. So he, I think, has seen a variety of life. Let's put it that way, on many sides. So Dan's been here for about a month, is it now, Dan? And is settling in well and bringing a lot of very interesting approaches from his former hospital, which obviously it's always good to get ideas from elsewhere. So welcome to Dan. And just a note on Aruna. Aruna will be very familiar to you. Aruna was an associate non-exec director, but since, if you remember last time, Steve Poulton, it was his final meeting, so Steve has left us and Aruna has now been appointed as a substantive non-exec director in Steve's place. So thank you to the Appointments Commission for agreeing with all that, and Aruna is now substantive non-exec director. So I think they're the only changes that we have in terms of our team. We'll move on now to strategy. It's a big paper We're going to talk about the results of the engagement programme, which many of you will have contributed to, which I think were very interesting, very successful, and I would at this point just like to congratulate everybody, but particularly Lisa, who led the engagement programme on the ground and worked incredibly hard to get around as many people, groups, organisations as possible. We'll then blend that into the strategic outline case, which is essentially a document which looks at the options for the future for us. Clearly the future rushes up on all of us, and I think you've already heard this morning how our facilities clearly just are not either appropriate for the 21st century, and it's very interesting to hear what James was saying about how he'd been in a different critical care unit yesterday and the differences, and any of us who've been to a more modern or a newer hospital will immediately be able to see what the future can look like. I don't think anybody in this room would disagree that we need to provide the best physical facilities for healthcare in the 21st century. I know that people in this room, some of you, will disagree on the various ways in which that can be done, but I don't think that any of us have, if you like, a fundamental problem with improving the physical standards of our facilities. So, a lot to talk about, and what we'll do is we'll go through the presentation, and then rather than wait right till the end of the board meeting for questions, we'll offer the opportunity for questions from the public on the engagement programme and the strategic outline case, and then when we've got through those at a certain time, we'll go back to finish off the board meeting. So, Daniel, over to you. Thank you.
Thank you. Morning, everybody. We're going to talk you through this, the strategic outline case, from beginning to end. And the way this is going to work is we've divided the presentation up into little sections. So at the end of every section, we'll have a little board conversation. And then, as Lawrence said, at the end of the whole thing, then we'll have a public Q&A. So there are 3 documents you should have, which are now also on our website. So this is the 50-page strategic outline case. This is a more readable version of it, a summary version. And then this is the document which feeds back all the engagement responses that we had. I think it's really important to begin by saying the reason why we're able to talk about our future is because our current performance is very strong. And this infographic, I think nearly all of you have seen, it's from the annual report from last year. We've had lots of questions during all the engagement which says, well, you don't think you're going to have a new specialist facility until 2024, but your commitments only go to 2020. So we're making the commitment to keep our commitments until we get to a new specialist acute facility. It's a great shame that we haven't managed to get the slides to actually fit on the screen. Can someone go away and work out how to get the thing to work? The case for change. So just to summarise, we have 3 very big issues that we're contending with. We aren't clinically viable, our state isn't functional, and we're not in great financial health. So just to summarise each of those. This is getting complicated because I can't actually remember all the words. The gist of it is that they're providing care for the sickest patients across 2 sites is very difficult, particularly given all the aspirations the NHS has for a 7-day service. And if we were going to deliver a 7-day service meeting all the quality standards on 2 sites, we would need 22% more consultants. They aren't there to recruit. We're also massively struggling to fill the junior doctor rotas, and in 3 months this year we spent £2 million on agency staff for junior doctors, and this can't carry on. Now, the next slide is a picture of the buildings, and it shows you the bed spacing between that we used in the video, showing you the surgical ward and Swelliok, showing you one ward has a fantastic bed spacing in Swelliok and the surgical ward doesn't, just to give you an illustration of the things we could never sort out in our buildings in their current form. And then, are we going to be back to...
Hopefully. No, I hope we're not going to be back to what we were.
Slideshow, possibly? From current slide would be brilliant. Thank you.
Is that it?
Perfect.
Thank you.
Yeah. Right, so that's the bed spacing slide. And then this is an important one, which is if we were going to keep 2 sites and bring the St Helier site up to a functional level of suitability, whilst leaving Epsom broadly as it is, it will cost £398 million, of which £190 million we have funding for, and £208 million we do not. And then on financial viability, you can see over time the trust deficit is getting bigger and bigger. And if you took out the non-recurrent funding we've got this year, it's £37 million. And if you project that forward to 2025, assuming that all the non-recurrent funding magically becomes recurrent, you still end up in 2025 making a £40 million a year deficit. So the summary is quite stark. We can't sustain the delivery of acute services on 2 sites in perpetuity because we can't meet the required quality standards, the estate isn't fit for purpose, and the ever-increasing deficit stops us being able to invest in the doctors and the buildings. So it's probably worth just stopping there, Lawrence, just to confirm with the board that the...
Yes, I mean, clearly the figures speak for themselves. The deficit just continues to increase inexorably, as everybody knows. Our financial plan for this year is for a planned loss. We agree all these losses with our regulators, so there's no, if you like, there's no surprises in that. So the regulators absolutely expect us to make a loss and are, I assume, content for us to make a loss. But clearly, the idea of being able to have no deficit means that we could do far more with our resources. You've seen from the photos, and I'm sure many of you know from personal experience from wandering around about the standard of the facilities, and compared to what we could have and should have and what you should have, they are not adequate. And I think Daniel's outlined very clearly the challenges in finding workforce to staff up 2 acute sites in a position in London, which is very challenging all over London, and one that is projected only to get worse. I'm wondering whether James or Ruth or maybe Ian might want to comment from a, if you like, from a medical perspective on the workforce challenge over the next few years.
Shall I start to make a comment, and I'm sure my colleagues will add to that. I think just to highlight for us what the key medical workforce challenge is in terms of the standards that are referred to. So one of the core standards that we ought to be achieving is that every patient who requires an inpatient admission and is an inpatient bed should be seen by a consultant every day. So it's not just the patients being seen within 14 hours of their acute admission. It's the ongoing daily review. And that for us presents a huge challenge and really is a significant driver of the increased number of consultants we would need if we were to meet that challenge.
And I think it's compounded operationally by the numbers of junior doctors that we have to support the consultants doing their reviews on a regular basis. It is clear that nationally and within this region there is a shortage and will be an ongoing shortage of particularly middle grade doctors to provide the specialist but more junior level support for these patients, and sustaining this level of Staffing on 2 sites has become increasingly challenging over the past 2 years, and we anticipate will become even more of a challenge year on year into the future.
Right, and I suppose to comment from a medical workforce perspective, from medical school background, so the changes in, for example, working hours, an inevitable consequence of that is fewer, larger acute services. And the model of within one trust of having 2 acute sites is really anomalous. And I always find it surprising, that it continues to exist on that basis. So inevitably there has to be a move to a single site. In terms of availability of the healthcare workforce in general, in fact, the government actually reduced medical school numbers a few years ago, which was a slightly bizarre move. The increases that have been announced that Jeremy Hunt has been talking about will increase our intake from 2019, but it will take till almost 2030 before these individuals are through, done their undergraduate training, done their postgraduate training, and coming into senior positions. So there's a deficit in the medical workforce for a long time to come that we're going to have to manage before things get better.
Yes, thank you, Ian.
Can I just put Rakesh on the spot and just to tell you about, it's not sustainable from our regulator to keep this level of deficit, is it?
So the financial regime the regulators have imposed on us, where they agree a level of deficit for each trust, is not sustainable. So I foresee that in the coming planning round, that regime will lapse, and I think trusts will be asked to deliver surpluses, as they actually were not long ago. So the target not so long ago was for every trust to make a 1% surplus. The regulators recognized that wasn't doable for many trusts like ourselves, and they changed the governance regime. And I suspect, and all the mood music is that will change. It will revert back to trusts having to make and become financially sustainable. So this regime, I think, is on borrowed times.
Yeah. So in the context of all of that, we did a lot of work on a clinical model. And to remind you what that was, it is 85% of our patients will always remain treated at Epsom and St Helier, whatever we do with the specialist acute services. And those services are local A&E, 24/7, both sites, all of outpatients and diagnostics, elderly care services, including hundreds of rehabilitation beds, antenatal and postnatal care, the planned work that we do, and including keeping the South West London Elective Orthopaedic Centre at Epsom and growing it, and keeping renal at St Helier and growing it. So 85% of our patients, no change to location, but they will be treated in upgraded buildings. And then 15% of our patients, the ones who are acutely unwell, we'd like to consolidate into one specialist acute facility. And the 6 services that relates to are emergency surgery and critical care, which are at yellow in the bottom. They're already consolidated, we only do them once. And then 4 additional services to consolidate, which are inpatient paediatrics, the birth part of obstetrics, the majors part of A&E, and complex emergency medicine. So that was the clinical model we engaged on, and let's just confirm from medical directors and chief nurse, there's a lot of clinical support for that model.
Absolutely, the overwhelming vast majority of the consultant workforce have endorsed the proposed clinical model and are very supportive of what we are proposing.
And from the nursing and midwifery perspective, that is hugely supported by them too.
And the final thing I'd add is that the model was actually developed in conjunction with working with those clinical directors and leads of all the clinical services. So they have been very involved in drawing up the proposed model of care.
Okay. So Sandra, we'll do questions right at the end for the public. Okay. So then we get on to engagement. What did we do in engagement? So we engaged on 3 scenarios, essentially on how to deliver this clinical model, which were have the specialist acute facility on this site, have it at Epsom, or have it co-located with the Royal Marsden in Sutton. Over 13 weeks, we did a pretty extensive engagement. And the We held 31 staff briefing sessions. We worked actively with the 3 health watches, particularly with Sutton and with Surrey and Merton. I spent a long time with 7 MPs, 6 councils, 28 residents' associations. The list goes on and on. The really important point about this slide is that the Consultation Institute, which is the kind of the recognised body for evaluating how well you do consultation stroke engagement, have reviewed everything that we did, both in how we did it and how we are reporting it, and have given us their endorsement that this is a best practice example of how to do pre-consultation engagement. To give you an idea of what that translates into in people, we can evidence that 25,000 people in our catchment actively participated in the engagement exercise. That means they either watched the video, I spoke to them, or they opened all the pages on the website. And if you counted all the coverage that the media gave to, you could say the reach was hundreds of thousands of people. We asked 5 questions in the engagement, and 1,059 people answered the 5 questions that we asked. There's lots of other feedback too, which I'll come to, but in the specifics of what we actually asked, then 89% of the people who answered, of the 1,059, agreed with our aim to provide as much care locally as possible from our existing hospital sites. Then 79.8% of people agreed that we have made the case that we will improve patient care by bringing together the care for our sickest patients onto one site to make the specialist acute facility. I think that is a much higher percentage than we ever thought that we would get for that question. Almost 5% of people said there were other scenarios that we should consider other than the 3 we engaged on. And of the 50 people who then gave us the, what they thought the other scenarios were, here they are. There's build a new super hospital, and I can confirm that was not from Daniel. Choose one or both hospitals, demerge, close, rebuild, the usual other list of things that you could think of. And then we had 37 separate responses from official stakeholders that were broadly supportive of the clinical model. That does not mean that everyone on these lists agree on a site. Remember, we didn't ask a site, and lots of these stakeholders expressed a view on a site, but the most important thing they did was express a view that they agree that having a single acute specialist facility is the right thing to do. So that includes a huge percentage of the very senior trust staff. It also includes our trades union stroke staff partnership representatives, and the one union you can't quite read, that says Unison. That's the all of the unions who are represented in the staff partnership forum. We received letters from 4 local authorities, so Epsom and Ewell, the London Borough of Sutton, Mole Valley, and the Borough of Reigate and Banstead. And all of these letters are all now on our website, so you can read what all these organisations said. And then 5 MPs support the clinical model, so Sir Paul Beresford for Mole Valley, Crispin Blunt for Reigate and Banstead, Tom Brake for Carshalton and Wallington, Stephen Hammond for, he's got a very long title, hasn't he, Wimbledon, Rains Park, Morden and Motspur Park, and Paul Scully, who is Sutton and Cheam. 12 residents' associations also wrote, and there is, on the left, one group from Epsom, which is, I think, all the residents' associations together. And then on the right, you've got Belmont and South Cheam, Bookham, Cobham, and Shanklin Village, which is the housing that's very close to the Sutton Hospital site on the right if you're driving down from Sutton to the A217. There is also, from the local NHS, a really positive letter from the Royal Marsden. The 3 acute hospitals in southwest London, which is Kingston, Croydon and St George's, so all our neighbours, have written a supportive letter. And then Surrey Heartland's Surrey Heartland's Health and Care Partnership Transformation Board, so the STP that is in the Epsom geography, has written as a collective. So that includes all the providers in Surrey, so that's Ashford, St Peters and the Royal Surrey Hospital in particular. And there is a common theme from all of the NHS stakeholders where they say, we support your need to have a single acute site, but wherever you put it, it will have an impact on us. So please make sure in the next phase you do the work properly to understand that impact. So those were all the positive stakeholders' responses. There is one neutral response, which is from Surrey County Council. So they are was very supportive of the need to engage, but declined to comment on the clinical model at this stage. And then we have 17 stakeholders who responded that they were not in favour of the clinical model, and that includes the London Borough of Merton and 13 of its councillors, Central Medical GP Practice, the MP for Tooting, whose catchment we do not serve, and Carshalton and Wallington Labour Party. Siobhan told me this morning that I thought I had agreed with Siobhan on Friday that she'd like to be in the next category, but she told me this morning she also wants to make it very clear she's in the category of does not support the clinical model. So we will update all the documentation to reflect that change during the day. Because then we had a next category of stakeholders who don't think this is the right time for Epsom and St Helier to be talking about its future. And Chris Grayling is very clear that that is where he sits. He's the MP for Epsom. We then received 23 petitions from local groups and 193 letters. And those petitions and the letters are all people campaigning for no change to services at St Helier. And you can see that's quite a lot of people from quite a lot of different organisations. And where those petitions have been organised by the Labour Party, we have documented that in the feedback. So aside from the high-level numbers, there are three really big themes that emerge in the feedback. And they are access, and mostly that's about if you move the specialist acute facility, how do I get to it? There are 400 mentions about about transport. There is a really big theme about deprivation and health inequalities and what is the right level of healthcare for people who are generally on lower incomes and particularly focused around the catchment we serve for the north part of St Helier. And then, as I've already said, a big theme about what is the impact on the rest of the NHS from what we do. And then we had a smaller number of themes that relate to how are we going to fund this? Will this actually happen? What are the timescales? So there we go. That is a summary of the engagement. So probably pause there.
Yes, thank you very much, Daniel. I think, I saw and indeed was part of the huge effort that Daniel, Lisa and everyone made for the engagement, and I really do think that they should be complimented on the huge and extensive reach that we managed to get. The Consultation Institute have said that this is an extremely well developed engagement program, and I'm very pleased that we managed to reach all of those groups, all of those individuals, and get such reactions, such strong reactions from all sides, because clearly not everybody is going to agree with everything, and it's good to know what people agree with and what people disagree with, and it's good to know that early so that we can understand people's concerns and hopefully allay any issues. However, are there any other directors who would like to ask any further questions on the engagement programme? Lisa, oh, sorry, Pat first and then Lisa.
I just wanted to put on record a huge thank you to the Health Watch organisations who did a tremendous amount of work. The numbers when people look on the website might look small in terms of those that turned out to the meetings they held, but they did a huge amount with their networks to reach some of the people that we potentially wouldn't have reached through our engagement exercise. So I think it's important to note that, Chair, if that's okay.
I just wanted to ask about the themes. The themes that came out were very important, and I just would like to understand a bit more about, we haven't discussed this, we have discussed a lot of things, but what the process will be for us to explore those themes, because the next stage, as I understand it, would be commissioner-led. So, I mean, to what extent will the commissioners need to do this, or will we need to do this?
Yes, I mean, I'll ask Daniel to comment in a minute in more detail, but my understanding is that the engagement and the strategic outline case will be a very important input into the forthcoming refresh of the South West London STP, which is coming out at the end of this month. And also, as Daniel has said, the Surrey Heartlands team will also be taking all of this on board. As to the detail of how the next steps work and how long it all takes, I think, personally, I think we will need to wait until the STP refresh is published at the end of this year to see exactly how that's all going to work. But maybe, Daniel, you can shed more light on this.
So the purpose of this engagement phase is to find out what are the issues that people have. So what is really clear is that the NHS will not be able to do a public consultation, if that's where it chooses to go, unless it has satisfactorily addressed the issues that have already been raised. So there has to be, for example, a really big piece of work on in the three sites. How would people get there, and what improvements would have to be made to transport to enable that to happen? There has to be a piece of work on what exactly are the health needs of people from more deprived backgrounds, and how do we ensure we have met them properly in all these changes. And there has to be a really detailed piece of work with all the other hospitals about if in any of the scenarios some of our patients who we currently treat end up in a different hospital, ensuring that they have the staff and the buildings to enable them to look after them well. Because we have to end up with all of our catchment having great access to first-class NHS care. So each of those three themes is a lot of work to ensure that we do it properly.
Yes, and I suppose for clarification for the board, who actually does do that work in the next stage? Do we do it? Do the STP do it? Do the commissioners do it? Do NHSI do it? How is that actually going to be? How are those questions going to be answered?
So I think it's a joint endeavour. So for the health inequalities piece, that is a commissioner-led piece of work. For the transport piece, that's a commissioner, provider, and STP piece of work. And for the impact on other hospitals, that's mostly down to us to work out. But the volume of work that has to come next is really huge and would in the end be a very large joint effort between the whole of the NHS family to get it done.
Thank you. Yeah.
So the next bit is, of the strategic outline cases, we've called it the technical analysis. So there's quite a lot of numbers now in this bit. So does the clinical model we proposed stack up financially? So the first place to start is, well, how many beds are we going to have in the future? Here is the answer, which is broadly the same number that we have today. So you can see on the chart, 1,026 is how we have modelled in 2025 if we were keeping 2 acute hospitals going, how many beds we would have. And then in each of the scenarios, we've looked at how many beds would Epsom and St Helier have, and how many beds would the other providers have of patients who would have come to us, but in that scenario have ended up in a different provider. So you can see that there is a small reduction in the number of beds over the time, and that purely relates to efficiency savings. So once you have built a hospital that is clinically functional, so you have all the right services in all the right places, you will definitely get an efficiency gain from your medical staff of not having to walk quite so far around the hospital to see their patients. And so length of stay will come down slightly as a result of making better use of your clinical staff. So broadly the same number of beds, first point in the technical analysis. Then how much capital do we need? And you can see that we would need the £208 million in the keeping 2 acute hospitals running, which we have already mentioned. And then in the, oh dear, we've lost the, we're going to reformat these slides, definitely. We've lost the titles. This one is, that's Epsom, 377 million. That one is St Helier, 396 million. And that one is Sutton, 444 million. And you can see that There are two rows. The top row is how much for in Epsom and St Helier, and the second row is how much is the capital in the other providers to provide the beds that would have moved to other providers. So the range in between the three sites in capital is quite small. The absolute amount of capital needed is large. We have appropriately used the Department of Health methodologies to cost the capital. We have made our best guesstimate about how much it would cost for the patients in other hospitals. And really importantly, we have modelled borrowing the money at a 3% interest rate, which assumes that it is funded by the government. We have done a separate analysis of PF2, which you will see in the main document, and the costs of PF2 are high, so therefore we haven't used them as our preferred method of getting the funding, but you can see the workings out on that. So we need between 377 and 444 million to build a new specialist acute facility. In doing that, we will make a lot of financial benefits, and they come to up to £57 million every year. And this is how we've worked them out. So in workforce, we will eliminate our spend on agency staff. On technology, we will move to a digital hospital so we can end the use of paper, which is a fantastically expensive way of running anything. We will spend a lot less money maintaining our buildings. We will become more efficient because the buildings will be better designed, which will reduce length of stay. And we are proposing that we do increase the amount of private patients we have by 1%. If we do the co-located option with the Marsden, it generates a further £8 million worth of benefits. So the financial benefits are considerable. What that does to the trust bottom line is that we go from a £40 million deficit to somewhere between a £4 million deficit and a £5 million surplus. So any of the three consolidation scenarios make a very significant absolute reduction in the trust deficit. The relative difference between the three scenarios, as you can see on the pink bars, is really quite small. So then we're saying at the end of that financial analysis, any of the three single site consolidations financially pass the test at this stage. You cannot differentiate and make a decision based on the finances at this point in the process of any of the three. What you can say is doing any of them is much, much better than doing nothing. So let's pause there, because that's lots of information.
Yes, thanks very much. I mean, just to reiterate, as Daniel has said, there is no the marginal differences between the three acute options at the moment are really quite marginal. There's a huge amount of extra work to do in the next stage to be able to focus on which of the three options might be preferred. That would include work on access, transport, travel, obviously public transport improvements, a lot of work on indices of deprivation, because we would need to weight that accordingly to see how that worked out in the balance. And then the impact on other NHS trusts in the area. Some of the options have a bigger impact than others, and clearly that would be a financial consequence for the NHS as a whole. What that all says to me, as someone who quite likes the idea of doing things strategically, is that actually this is a South West London and Surrey issue, because whatever we do, it's going to have an effect on other people and other trusts and on the health economy generally, and it's also going to have an impact on transport. It's going to have a hopefully beneficial impact on people's health and healthcare, on the community. So this is a decision which actually has ramifications throughout the whole of the health economy of South West London and Surrey. And because of that, in the next stage, it won't be just us looking at this, but many other organisations will have to be involved in this, and that's really why we are presenting this today, because we're really trying to get everybody else to be able to come into a position where they can take it forward, because strategically this is a system-wide issue. Rakesh first.
Just a small point, Chair. It's important to recognise how we've arrived at the numbers. So, although the Trust led on working on it, I met and I was meeting regularly with the finance directors of the local CCGs, the STP, and our regulators, and we jointly developed the underlying assumptions that derive these numbers. And we recognise there's further work to be done at the next phase. But these numbers were developed jointly with the local NHS and our regulators, NHS Improvement and NHS England.
Right. Daniel, 400 million in capital sounds like an absolutely vast sum. What's the risk that that will be deemed to be unaffordable with external groups looking for alternative solutions that aren't Epsom St Helier at 400 million?
Well, now we can begin to work out how risky that is, because currently we have been speculating about all of this. Now we have done all the work. We can now submit all our work to the NHS for them to actually make an informed decision on. I think we're doing it on the basis of two really important things. Firstly, the return on this investment is really very positive for the NHS. You will pay back the entire capital in 10 years. That's almost unprecedented. And I think from the engagement piece of work, we can demonstrate that really a large percentage of our local communities are up for a degree of change in order to get a 21st century NHS. But it's also really clear that we will not be able to do a public consultation on this without a decision in principle from the government that they are willing to fund this. So the next 6 to 9 months are now really important about how do we demonstrate to up the line that this is actually the right thing to do, because we do want quite a big share of the national capital allocation. But I think that our need to have it is huge, because there are so few other hospitals that are in such a poor state than we are. So I'm cautiously optimistic that we have done all the right groundwork so far to have a very credible case with the decision makers up the line. So the next bit is, what do these three scenarios actually look like? So here we go. So this is carrying on as we are today. So 2 acute sites, and the red shape, that is our current catchment of 490,000 people. Here comes the next one. So this is the first. This is Epsom as the specialist acute site. And to orientate you, that's the Dorking Road. So you would build the new facility on the car park at the front where the car boot sales currently happen, and on the top of Headley Wing. And the current visitors' car park becomes a multi-storey. And what you can see for the catchment is we lose the whole of the top of the red blob, and it comes under just under 300,000 people is what the catchment of the hospital would be. This is what the specialist acute facility at St Helier would look like. So to orientate you, there's the main road. That's the front entrance currently. And what you do is you extend A, B, and C blocks backwards over the top of the current maternity, paediatric, and renal buildings, and you put a huge multi-storey car park on Ferguson House and the current part of the current car park. And you can see in the catchment, we lose a good chunk of the Surrey catchment as a result, and end up with 369,000 people using our hospital. And then this one is Sutton co-located with the Marsden. So this one's quite difficult to orientate because nearly all of this doesn't currently exist. But the red buildings is what the Marsden will look like in 2025. And there are quite a lot of buildings there that aren't currently built, but they are in the process of building. And the blue would be our buildings. And what you can see, it really is co-located. It's bunching right up next to them so that the buildings can actually be connected, so clinicians can work between them. And you can see it completely changes the trust catchment as well. But we end up with 418,000 people, and we needed, ideally, to get over 400,000. So that's what that looks like. Trevor's done a huge amount of work on designing all of this bit.
Yes, I mean, the only question I had would be this. If we were to build the new facility at, well, any of the three places, clearly we've stated that 85% of our patients still go to where they are currently. Do all the estimates include the necessary rebuilding and modernisation for the 85%? So, for example, were we to develop at Sutton, does that capital clearly include all the work that would still have to be done at St Helier and Epsom to make it fit for purpose?
Yes, Lawrence. So the plan is that we've looked at all the options, and part of the work we're doing now is trying to look at what buildings would be retained under any facility, any option, and we plan that any future use of Epsom or St Helier hospitals would have 50% single rooms. We wouldn't necessarily fully comply with bed spacing. I think that's just not affordable because the space that we require, but we'd greatly improve our facilities and the space. So, for instance, a 4-bedded bay in one of our normal wards at Epsom in Wellswing would become a 2-bedded bay with ensuite facilities.
Yeah, Daniel, you made a passing reference at the end there, which was something to do with we needed to get over 400,000 as our catchment area. What does that mean?
So the ideal size of an acute hospital for the future in terms of patient volume is 400 to 500,000 people, because that enables you to make the best use of the clinical staff. I don't know whether Ruth looks like she wants to comment.
I was just going to say it's that, and also about making sure that the staff that you appoint have sufficient kind of clinical time to actually maintain the skills that they need to maintain.
We can't continue running acute services on 2 sites in perpetuity because we won't meet the quality standards. We aren't clinically and financially viable. We don't have buildings that are functional to do it in. We do not believe this is an option that we should be continuing to consider. Our proposed clinical model makes us clinically and financially viable. In each of the 6 acute services, we will have sufficient workforce to deliver all of the quality standards with the workforce that we have now or are in the process of recruiting. The absolute difference between any of the scenarios and maintaining 2 acute sites is huge. The relative difference between them on the finance we've done so far is small. A significant amount of capital is required, and we are at this stage not identifying a preferred scenario. And just to give you, here is the finances overall in one table. So beds the same, the capital bit in the middle. This is the return on investment to the NHS calculation, and this is the Trust's financial position in each of the scenarios. And so we're recommending that there's a lot of further work that needs to be done with our commissioners to enable a preferred option or options to actually be consulted on. So our request is that commissioners will need to work with stakeholders and the public to determine the non-financial criteria to evaluate the different scenarios. And we'd like them to do that based on the information we have collected in our engagement, which means it must consider the themes of access, deprivation, health inequalities, and the impact on other hospitals. And I am sure that stakeholders will have other non-financial criteria they want included too. This is how we consider what's a timeline for the future. So as of today, we are now submitting our strategic outline case to our regulator and to the CCGs and the STPs. We'd like them to come up with a decision on whether they agree we, as a system, can proceed before Christmas. We'd like to end up with a pre-consultation business case in the summer. We'd like to do the consultation in summer, autumn next year. We'd like there to be an outcome of that consultation in spring 2019. And assuming all that happens, it is conceivable that a new specialist acute facility would open at some point between 2024 and 2026. The 3 different scenarios take different lengths of time to build, which is why there's a 3-year time frame for the facilities opening. And that's where we have got to.
Thank you very much, Daniel. As Daniel has said, it's big choices to make. Nothing is going to happen for visibly, if you see what I mean. We won't be getting any diggers and bulldozers in for a long time. Things do take a long time in the NHS, and there are a huge number of steps to go through. If I take anything from all of the work that's been done, I would say that it does seem very clear, and the financial figures up there, you know, they're indicative. They will change. We all know that, but it does seem very clear that putting, well, actually, it's only 4 of our services which are currently on 2 sites onto 1 site. So 4 of our acute services, which we currently operate on both sites, combined on 1 site, to go with the 2 that are already on 1 site, will mean that for the 15% of our patients who are either the sickest or require acute facilities because they are having a baby, for those 15%, they will get a much, much, much better standard of facility and care, and the clinical, operational and financial consequences of doing that are very, very positive. But I would stress that for 85%, for the vast majority of interactions that patients have with our hospitals, they will continue in the same place as they continue today. So for all your outpatient appointments, diagnostics, follow-ups, renal dialysis, everything that's done on, if you like, a planned basis, you would continue to come to where you come to now. So we're doing this for the sickest patients, for the patients who really need some better facilities. And I think, in a way, very coincidentally, this morning we heard from people who'd been around St Helier this morning how the physical standard of the facilities is the thing that really holds us back and isn't right for our patients. It's just not appropriate. As to which of the sites, personally, I still have a completely open mind. I can see advantages and disadvantages on all of them, and I can see a path to achieving something on any of them, and I can see obstacles to achieving anything on any of them as well. I would just hope that the system, when they receive our documentation and our reports, once we've approved it, that the system takes the same view of us, that we need to look at this in more detail. And as long as we can get to that point, so that by summer or autumn of next year, we have answered a number of those questions, we've got far more information and detail about the options, then I think that will be very positive. So that's all I wanted to say at the moment. I don't know if any other directors want to add anything. Pat?
Well, I'd just like to say, as the chair of the Patient Safety and Quality Committee, that there isn't a single meeting that we have, when we have them on a monthly basis, where the issues of both the medical workforce and the condition of the buildings doesn't come up in some scenario or other.
Right, so we've got some time now, so...
No. So Lawrence, I think the board has to make a decision.
Oh, really? I'm sometimes not quite up to speed with the processes. We do have to make a decision as to whether we, as a board, adopt this. So we've heard the engagement, we've heard... I'm going to ask Peter, he's our expert.
So technically, this is a meeting in public, not a public meeting. So the board needs to make its decision. You can choose whether you have the questions now or not, but the point is this is a board meeting in public. The board does need to make a decision.
Right. Well, in that case, I'd like to take the questions first, because I think that they will add to the debate, and then we'll take a decision after the questions. So now for questions today, it's a slightly different way of doing it than just shouting out. We're recording it, so there's a microphone, and Meg over there has got the microphone, so I'm going to ask her to go through and hand the microphone to those of you with hands up. Can you, because there's more of you than usual, and I'm afraid I don't know everybody's name today, could you just say who you are, and if you represent an organisation or a local group, just say that too, and that will be helpful.
Hi, I'm Claire Jackson Pryor, Sutton Green Party and COSH. Just an observation on the meetings that have taken place, as Daniel and a couple of others will know, I've been to a number of them. But the rest of the board has not. And what I observed is quite frankly, whenever anybody's been saying that they do not agree with the single unit scenario, what I have observed is Daniel then saying, well, if you don't agree, you'll get nothing. Yes, that I regard as having put the audiences under duress to get the answer that he wanted, and I wanted the board to take that into consideration before you make your decision.
David Murray. I'm a patient about to go into Epsom next week for an operation, and the treatment has been fantastic, as has every time I've been here for A&E. They've been absolutely marvellous. Now, Daniel, you said large proportion of local people back the change. It's about 1,000 out of 500,000. It's about 0.2%. That basically confirms what the lady from the Green Party just said. This is not something that is overwhelmingly the product of 500,000 people by any means. Number two, you keep talking about the 85%. Now, you see about 150,000 A&E patients every year, and in all the scenarios, you'll continue to provide a local service for 100,000 people. If you actually put the acute centre at the Marsden, there will still be 100,000, i.e. 66% of people who will be affected by this, who will go to A&E at St Helier or at Epsom. The 50,000 are the acute ones, the very sick, who will go to the Marsden. So it's not true to talk about 85% unaffected. It will affect 66% of people going to A&E. And if you have all your consultants at the Marsden, or the majority of the very skilled consultants at the Marsden, you will not have those people at Epsom or St Helier. You will be, in fact, implementing a two-tier A&E system. The third question I have is, basically it is a question. You keep saying that you have to continue with this model because you won't otherwise meet the quality standards. Why won't you meet the quality standards? And if that's the case, and there's only one possibility, maybe the quality standards are suspect.
So let's do a Daniel medical director double act here. So is 1,000 people significant in answering the engagement questions? For an engagement exercise, that is a massive response. Remember, we didn't do a consultation on this is what we're trying to do. We did an engagement on this is the clinical model. And one of the reasons why we got such a strong endorsement from the Consultation Institute is that they're saying that how we did that was exemplary. In terms of, you say that, yes, you are right for A&E, it's 66% of people will have a change, but take the example of Swelliog, 100% of people have no change. So when we say 85%, we've aggregated up the entire patients who we treat and said, of all the patients who we treat, what percentage will have to change their location, and 85% do not. One more point. So in answer to, I have been saying really clearly in these meetings, and that's why we made the point right at the beginning of this presentation, we can't carry on as we are in perpetuity. If we do not secure a new specialist acute facility, what will happen is really clear, is that over a number of years, we will not be able to staff one or more services at Epsom and St Helier, and they will close. And over time, the volume of acute services this trust can deliver will go down. And they'll go down for exactly the same reason as why we can't meet the clinical quality standards that we have been set because of the availability of the workforce. Cue Ruth.
Ruth, can I ask you to answer on the quality standards? The point was made that maybe the quality standards are wrong.
So the quality standards are nationally derived quality standards. They apply to all acute trusts, and there is an evidence base that underpins them. There are 10 quality standards that all trusts are to implement. And, you know, I think you have to look at this from the perspective of if you were in hospital, if a relative of yours was in hospital, would you want them to be seen by a consultant within 14 hours of admission? I think yes. Would you want them for their ongoing stay to be seen by a consultant on a daily basis? Yes. Would you want them to have access to diagnostics 7 days a week? Yes. Would you want them to have access to consultant-delivered interventions 7 days a week? You would. So these are standards. There are standards as a clinician that sometimes do not resonate. Yeah, and that exactly is the argument, that actually these standards will drive up the quality of clinical care that we provide. And it is that is our responsibility as clinicians, as medical directors, to actually push forward.
Hello, I'm Sandra. I'm a member of COSH. We will be submitting our engagement numbers in the very near future. We attended almost all of the meetings that Daniel did. We attended as many as we could find out about. And that was not made easy. In fact, Daniel was frequently very surprised to see us turning up because he hadn't advertised these meetings on their website as they promised they would. However, can we be clear, first of all, that all of this process to lose one or both of our local acute hospitals is actually about the STP, and the STP, or Sustainability and Transformation Plan for this area, we were told we had to cut in NHS spending £1 billion. And when that plan was brought out, the key money saver was that we should have, of the 5 major acute hospitals we currently have, we should be reduced to 4 or 3. And that's really what all this is about. It's a money-saving exercise, and the health of the local residents is really not important. It's about cuts. The standards that you were talking about were only introduced in about 2012, and we were told by BSBV at that time that although they had to impose those standards, there wasn't the money, and even if there was the money, there weren't enough consultants in the country to meet even our local needs of consultants, let alone the rest of the country. There weren't the consultants then, and there aren't the consultants now. You've had 5 years since those standards were introduced, and you have still not trained enough consultants and junior doctors to fit the standards that have been imposed by NHS, knowing they can't be met. This was designed to cut our NHS. It was designed to be an excuse to close hospitals. Your engagement process was dubious. The questions were vague. People's names and addresses were not asked for on most of the forms you put out, so they were largely anonymous. We spoke to people at the meetings, and a great number came away from the meetings that you held. You explained to them. They came away believing they were going to get either a new hospital or an additional facility. Most people at those engagement meetings did not realise that you intended to cut one or both of our major acute hospitals. You have said in 2015 that you would keep all the bed numbers and all the facilities until 2020. You have said that in your new acute hospital you would have 500 acute beds. In 2014, and I have the FOI to prove it, the Epsom and St Helier Trust had 759 acute beds. So you are planning to cut the number of acute beds from what we had in 2014, just before your promise to keep everything the same. We had 759 beds, and you are proposing in this wonderful, fabulous new facility that's going to replace our 2 major hospitals, you're only going to have 500 acute beds. How is that an improvement for anybody?
So some of those. So we advertised the meetings that were our meetings. I think that a number of the residents' associations were very surprised that people who weren't their residents came to their residents' association meetings.
And you made it very clear that we were their residents.
Well, I think the residents' associations made it clear that they wanted to have conversations with their residents. So that was my first response. The second one about I want to put this on record. We have asked you several times during this process whether you would give us the feedback that you have collected so we could include it in the engagement, and you have said you do not want that to happen.
I never said that.
Yes, you did. We've asked you that several times, and that is why there is no official response from Kosh in the engagement, much as though we would.
You asked me once, and I said I'd ask the rest of the group. That's the only conversation that's been had about it, and I had it with you. Is that true? You asked me once, and I said I'd put it to the group. Is that true? It was. Thank you.
There you go. So we would have liked to have had your feedback in the engagement, and it's sad that we weren't able to publish it when we have published everyone else's. In terms of can the standards be met? Well, just look at page 9 of the local newspapers today, and you will see the amazing results from the hip fracture unit, which once again we have performed way, way better than every other hospital in the NHS bar one. But hip fractures are acute services for the sickest patients, and what you can demonstrate is when you get the clinical staff together in one team for a larger population, you achieve amazing standards. We know that whilst the standards that have been set for the 7 days are aspirational, we know we can deliver them. So wouldn't that be great for 500,000 people to know that if you're acutely unwell, all of the quality standards the NHS has set we can make? And then lastly, on beds, you will see that we say we have 1,024 beds now because we have counted all the beds that we have. You quoted a subset of the beds, and I demonstrated very clearly on a slide that the bed numbers do not change very much in any of the scenarios. The 759 is a combination of acute beds and non-acute beds. Yes, it is.
I've got the FOI right in my hand. 700.
So every bed in a hospital is currently counted as an acute bed. We have done over successive years audits of who is in our beds. And what we discover is there are about 500 patients who are acutely unwell, who need the care and attention of the majority of the consultants. And there are about 400 to 500 other patients who are rehabilitating, convalescing from a major injury. And we're saying, for the future, you need to differentiate those two types of patient.
Out of the 1,000 or so beds you've got.
Other questions? Oh, lots. So.
Okay, can you hear me okay? Yeah, my name is Colin. I'm a concerned resident. Can I just remind you, in the light of this meeting, that the NHS is a service, it's not a business. In 2015, it was proved that an extra 30,000 people died in this country due to cuts in the NHS and social care. Bearing that in mind, Daniel's last position was in northwest London, where he oversaw huge cuts and closures himself. These plans, his vision, will result in fewer combined services, and more people will have to travel further if a facility is ever built. Given Daniel's track record, I think we should be very suspicious of his motives. I please ask you all to do not be collaborators with the privatisation of our I strongly urge you all to scrap these destructive plans.
Thank you. I'm Sally Kenny, an elected councillor in Merton. I did respond to the correspondence as a councillor, and it's not listed, a minor error. It doesn't matter, but how many other minor errors are there? Perhaps because I also wrote in the capacity as a resident. But one of my main concerns in my letter to you was the emphasis on local community and the density of the population in the surrounding area of St Helier. The density of, and this was factually looked at and figures supplied, which I can't remember offhand, that the density of the area surrounding St Helier Hospital is greater than the combined density of the Sutton and Epsom hospitals, and the need of the local people in the St Helier area is significantly greater. And I don't quite understand your figures, Daniel, that you came out with saying, if the new acute hospital was built, and you named the three, saying St Helier would have only 360,000 people. I don't quite understand that. I just don't think the consultation gave enough emphasis to local need. Engagement, I beg your pardon. Also, I am concerned, I can't read much about a consultant-led maternity unit because we know how vital this is on occasions, and it's essential we have it. So why not? The other thing is, in my quick read, can't see enough detail on the need of infrastructure for each build and the cost of that infrastructure for each site. And certainly, I think certain sites would be much more expensive, and I wondered if that was included in your overall cost. And I'd like to just highlight, it was Chase Farm Hospital that lost its acute unit. It did go from, I think, it was 800-bed hospital down to about 48. I may be wrong on those figures. I'm relying on memory. And I think this is a huge, huge worry to local people. And what guarantee do we have on bed sustainability for local people? Thank you.
Thank you. I'll just answer a couple of your questions, then I'll hand it on. I think you're absolutely right to raise the question of density of population, or the way I would interpret it would be a greater demand for health needs of certain parts of our catchment versus certain other parts of our catchment. And I think you're also absolutely right to raise the question about infrastructure and access. And I think, as Daniel said, we recognise that, and on the slide, those were explicitly mentioned. We will absolutely look at those in detail, or at least the system will absolutely look at those in detail in the next stage. We have not looked in detail at indices of deprivation. We just couldn't do that, given the amount of resource and time we had. We haven't looked at in detail the transport plans, access plans for the future. And of course, the indicative drawings that you saw of the hospitals, the plans of the hospitals, are just that. They're just indicative drawings. We are at an early stage. All we're saying at the moment is that we believe that combining those 4 additional acute services with the other 2, which we already have combined on one site, will mean that we'll be able to operate much more efficiently and effectively in terms of the future, as opposed to what we can do at the moment. But you're right, that all those questions that you raise, they will be looked at in detail over the next stage. And it could be that when they are looked at in detail, different weightings are given to different solutions. But we can't sit here today and answer that question because that work hasn't been done, but it will be done. And it's an important part of the next stage of the work. So that's what, I hope that can go some way to reassuring you. We haven't forgotten about it, but it's for the next stage.
But you do want to see the bigger picture. You said that earlier. It doesn't work like that. We're all aware
going to happen with this. You cannot put a quart into a pint pot. You will not keep two hospitals and another hospital running. Who's deluding themselves? It will not occur. One of those other hospitals, at least, probably both, will close. You know it, we know it. If anyone doesn't know it, then they should think a little bit more about it. That's our concern. Thank you.
Just picking up Councillor Kenny's first point, if you go to our website, you will see we have published all the letters that we have received, and yours is on the list of it's there, and you can see the letter that we received from you. In terms of the issue about the density of population, well, the reason why the different scenarios have different catchments almost exclusively relates to the density of population. So there are more people who live in this part of our catchment than live in the south. That's why if you concentrate the acute services here compared to Epsom, you end up with a much bigger catchment here than you do at Epsom. That is the result of the density of population. In terms of consultant-led maternity, let's just ask James to confirm we are having a consultant-led maternity unit.
So the clear plan is that the consultant-led maternity service would be based at the site of the acute hospital.
Well, Sandra, we don't know where that site is, actually. Well, not...
Emily Brothers, Sutton and Cheam Labour Party, but also a local resident living very close to St Helier Hospital. I had asked for accessibility as a blind person to the papers for today, and that didn't happen, which is very disappointing. So I hope that can be sorted out as soon as possible. Because it makes things difficult. I'd like to follow up a question, I think, from you, Chair, which I don't think an adequate answer was given. If we work on the scenario that the clinical model will be established in Sutton, adjacent to the Royal Marsden, can we have some clarity, therefore, on the 85% of patients who will be non-acute based here at St Helier? Firstly, how many beds will there be? And secondly, what investment, which I think was your point, Chair, what investment will there be in the St Helier site for those 85% of patients in order to make it fit for purpose? Because we've heard from Daniel and everybody else about the difficulties of this site. So 400 million for 500 acute bed in South Sutton, that's clear. But what is the vision for the St Helier site? In other words, how many beds and how much investment, and where will that investment come from?
Thank you, Emily. The 85% actually is for Epsom. It is for Epsom as well as St Helier, so it's for the two. Trevor did start to talk about it, but maybe, Trevor, can you just enlarge a little bit on the question that if, and I stress it's an if, but if the acute site were at Sutton, what would be the plans for both Epsom and St Helier?
So within the capital figures that have been identified, the work that's required on both sites, whether primary facilities on Epsom, St Helier or Sutton, is all incorporated. So the investment required to bring the facilities at Epsom and St Helier to meet the standards that we the best we can are incorporated in those figures.
And the bed numbers?
The bed numbers, I don't know off the top of my head, I'm afraid.
So it's between 100 and 200 at both Epsom and St Helier, possibly more. We need to do more work on the detail. In each of the scenarios, the size of the specialist acute facility varies too. So the key thing to look at the bottom, which is what we told you, is how many beds in total will there be in the trust, and it's 994 for the St Helier primary site. I think it was 992 for the Epsom site and 1,022 for the Sutton scenario.
Hello, my name's Cara Hernan. I'm a resident of Carshalton. My question is really that the figures you've given on the response, you said basically that 89% of local residents that responded were in favour of your model and how you wanted to proceed with the funding. And I imagine that's true, you know, the figures that you've given us for the people that responded directly to the engagement, but there are thousands and thousands of people that sign petitions that I know of, and I'm sure there are people beyond that that didn't want to give their unconditional support to this without knowing where potentially you were going to spend that money if it meant that you weren't going to end up with basically if it meant closure of any acute services or downgrading of any acute services, that they weren't in support of it. And I feel like you've really heavily weighted your own figures to say that all of these people support it when, 941 people do, and I know of at least 2,000 people that have written in petitions to say that they don't want to give their unconditional support, and from what I've heard, it is up to 6,000 people that have done that, but those numbers aren't in the back of here either. And the other thing I'm concerned about is you currently have 2 sites, and I know you want to consolidate your staff for the potential 3rd site or wherever this acute hospital goes, but to me that looks like a lot more staff, and you can't staff what you've got right now. So I just wanted to know how you plan on solving that problem, you know, when it arises. Thank you.
Well, so in the document you have in front of you, this one, go to page 29, and you will see a section on petitions, which is so we have recorded the petitions that we received. Yes. So with advice from the Consultation Institute, we have carefully grouped the responses we received into those people who actually answered the questions we wanted to know the answer to, and those organisations and groups who have told us this is what they think about the issue in general. And so we have deliberately included all of it into the engagement report because it all came out of us wanting to do engagement. But you do have to separate out the people who actually answered the questions we specifically wanted to know the answer to, and those who have told us in general that they support their local hospitals, which we wanted to capture and demonstrate that we have listened to that. So that's why we have categorised it as we have done.
Right, we've got time for maybe another 3. So who?
Thank you, Chair. I have 4 questions. I'm afraid they're important. Oh, that's true. Sorry, yeah. Do you want to?
So on the issue of staffing, we're trying to make the case, and we've said it many, many, many times. The issues in staffing are with the acute services that we need to consolidate. And if we do those 6 services once, with the staff who we have, we can deliver all the quality standards. Trying to do them twice means that we don't have the staff, we can't see how we ever could get the staff, and therefore we have a massive reliance on agency doctors, which isn't good. There are the staff to meet the standards when we provide the service once, as demonstrated by the hip fracture service. $490,000, has it? No.
Wasn't Bob. No.
Thank you. Question 1. I'd like to know how many trusts in London meet the quality standards that you are saying that you need to meet. In fact, I'd like to know how many trusts in the country meet those standards. Number 2, 1,059 responses, and I believe you said this has cost about £40,000. Do the board think that £37 per response is a good value for money? Number 3, I would like to know where the evidence is that centralising A&E services and maternity services onto a single site yields better clinical outcomes. And I stress, I do not want an answer about neck of femur or on anything other than those services. I would like to see clinical evidence that that will yield better results. And finally, we are experiencing a growth in population. The population in this area has never been higher, and yet you are proposing reducing the number of beds we have, or at best, maintaining it. So this is a question for the doctors on the board. If you are about to make a decision, you all took an oath. That oath was, first, I will do no harm. Could you lay straight in bed with a clear conscience, knowing that you are removing one of 2 acute facilities which will inevitably lead to patients dying as a result of the decision you are going to make today? Thank you.
Thank you very much, Dave. We'll take your questions in the order that they came.
Okay. So how many hospitals in their entirety are meeting all the 7-day standards? I don't know, but I would suspect not very many. But the standards exist because they're all evidence-based about improving patient care and outcomes. So the plan for the NHS is to meet them over a number of years. And we want to meet them for you, because you are important, and you deserve to have the best healthcare that you can. In terms of is it value for money, I would say that the most important thing locally that we can pick up from people is they really are passionate about their local NHS. And we want to make some quite big changes to the local NHS. So I think spending money on engaging with people to enable them to participate in the conversation is money very well worthwhile being spent. The better outcomes on A&E, I'll leave to the doctors. The issue about are they comfortable with what we're proposing, I'll leave to them too. And yes, we have factored in the growth in population. At the same time as the population is getting older and there is more people, medical technology means that you need less inpatient beds as a result. So if you just think of the shift that's happened from inpatient care to daycare, we're now getting a shift from daycare to outpatients, and you look at the number of people who actually we can look after in their own homes. So we now have a ward's worth of patients who are being looked after by a team of 50 people based in Epsom Hospital, but the patients are being looked after in their homes. They much prefer to get better in their home than they ever did in a hospital bed. So we have factored in all the different trends in the need for more beds and the need for less beds to arrive at the numbers we have got to.
Okay, James. Yeah.
In terms of how do I sleep at night and how will I sleep in the future, I think the thing that makes me sleep least comfortably at night as a medical director is the current shortage of doctors that we have, the challenges that we have filling our rotas, the fact that our consultants can't see patients every day who deserve to be seen every day, who need senior clinical decision making in a timely way. And what I do know, talking to the consultant staff who work in this organisation, is that they are united behind the clinical view that we would offer far better and far safer care if we consolidated our acute and complex services on a single site. there's absolutely no doubt that year on year it becomes harder and harder to sustain the level of medical staffing as the complexity of medicine increases. In terms of A&E, and we've talked about this, as you know, David, in the engagement exercises, that medicine is becoming more and more complicated. And when you have a very significant life-threatening illness, such as a major heart attack or a major stroke or a fractured neck of femur,
We're not talking about fractured neck of femur, we're talking about A&E and maternity.
So I'm just saying, when you have a major illness such as those, outcomes are better when the care is consolidated.
As long as you get there in time, in fewer sites, for less people. Yeah.
Do you want to hear the answer?
I would love to hear the answer, but can you please answer the question?
So when you have a major complex illness, your outcomes are far better if you access care where all the specialist facilities are in place and the specialist staff are co-located so that they can offer the care to you in a timely way and make decisions in a timely way. And exactly the same scenario happens when you have other major illnesses that needs you to present to the accident and emergency department. Your outcomes will be better if you access a hospital where people are co-located and can give you decisions in a timely way.
Right. I'm sure there must be some evidence, Sandra, but I haven't seen it.
So can I just... The evidence that we have in southwest London is that we have hyperacute stroke services, which are consolidated on a single site at St George's Hospital. The outcomes for stroke in London are the best in the country because we consolidate services. The outcomes, if you have a major heart attack, your services are co-located on a single site and your outcomes are improving. What we have done at Epsom and St Helier, we have consolidated our A&E services for acute surgery. So if you have an acute surgical problem and you live in the Epsom part of the catchment population, you will come to St Helier to access the A&E for that need. When we did that about 8 or 9 years ago, the mortality figures for acute surgery fell and stayed at a sustained level lower. When we consolidated our fractured neck of femur service on a single site, the outcomes have improved year on year, and now we are a national leader in the service that we provide for fractured neck of femur. And we propose to extend that to other major medical illnesses, such as presenting with acute pneumonias or other severe medical problems. And if I or one of my family had a similar problem, I would want to be able to access a hospital where there are senior decision makers available to make prompt, complex decisions and to talk to other members of the team and move your care forward.
So the reason why you can't get a simple answer to your question about A&E is because A&E is a place where people who are acutely unwell get treated. So the outcomes of people who are acutely unwell relate to the condition that they're unwell with. So we can tell you that when you consolidate onto one site those conditions and you get the expert team around, like the hip fracture unit, you get great outcomes. Okay? And that's why we've told you about hip fractures. We can tell you about trauma. We can tell you about heart attacks. We can tell you about stroke. All those people come to hospital via an A&E service before accessing the specialist service that they then need. So So what I'm trying to tell you, I'm trying to say to you, Mr. Ash, that the question you have asked cannot be answered because you have to ask the question about what are the conditions that people are presenting to A&E with. And what we have given you is lots of examples of how when you get a specialist team for a specialist set of illnesses together, you get much better outcomes, and you get them, for example, in Epsom and St Helier if you happen to sadly fracture your hip. Okay?
Okay, don't worry, I'll give you next.
So modelling the consultant numbers that we have in the different specialties, we do not propose to cut any consultants from our workforce. What we have enough consultants across our 2 sites to deliver the 7-day quality standards for the acute services on a single site. There is absolutely no plan to make any consultants redundant.
Do you, over there, sorry.
Good morning. I'm actually from Epsom and Ewell. I was voted onto the Epsom and Ewell Council, Borough Council, in 1999. And why is that relevant? That was the year the Epsom and St Helier University Trust was formed. And I feel I've been fighting to save the Epsom Hospital ever since then. There was a big meeting at Bourne Hall where they wanted to build a super hospital at Sutton. Meanwhile, Sir Adrian White has built Swellyhock on the Epsom site. He also did the new A&E unit. So there are parts of the Epsom site that you can't, because let's be honest, Epsom and St Helier will not survive. There's no mistaking that. They've got to shut 2 of the 5 hospitals in southwest London, and for some reason Epsom's included in that loop, so I'm fighting for Epsom. I'd like to know if the site is located at Epsom, what impact would that have on what's already there? I know personally it takes 2 hours to get to St George's from Epsom on public transport. It's only a couple of miles up the road from St Helier. So I'm not worried about that. And also we might lose the bus service that goes to West Croydon. And I am quite definitely here to fight for Epsom.
Thank you. No. Yeah. I'm going to, we're already 15 minutes over time, so this is going to be the last question because we've got the rest of the board meeting to finish. So,
thank you very much. Jonathan Perkins, lay member, governance, Surrey Downs CCG, although I'm not here in a representative capacity. Also a resident in Surrey, use the Epsom Hospital. I'd like to thank the board for their time this morning, holding this in public, and for their consultation, or rather their engagement. Looking forward to the consultation. I hear the message that there's a lot more work to be done, and there will be hopefully a full consultation on the 3 proposals going forward. What I'd like to do is ask one question, which is, can you just remind me, because I'm not sure I got it from all of Daniel's figures, what the do-nothing scenario looks like, because I seem to remember there was a large deficit talked about at the beginning, and a do-nothing seems to me the worst of all worlds. That was the first thing. The second thing I like to do is to encourage all the lay members on your board to join in all of these strategic discussions at the Surrey Heartlands partnership level. and we have a lay member working group to dovetail in all of the strategic thinking that you're doing here in with all of the other prevention and primary care thinking that's going on. Because, of course, discussion at the strategic level for acute hospitals is only one part of the overall system which needs to be changed. And if we're looking for a 10-year strategy to 2026, it's very important that we include the whole of the system, which will go to assisting with the workforce, assisting with releasing pressures on hospital by keeping people out of hospital and bringing them out of hospital quicker to be treated at home. And I'd like to applaud also, Daniel and colleagues, your support for Epsom Health and Care, which I think for the over 65s in Epsom has been producing a tremendous value over the last 2 years. Thank you.
Thank you very much. Do you just want to, about the do nothing? Just for clarification.
So on Epsom Health and Care, thank you for talking about it. So it's very exciting, and we're now in a very ambitious phase to extend Epsom Health and Care to cover more and more services and a bigger amount of the population, because it is really clear that the patients are getting much better standard of care because we in the NHS and social care are working together as one, as opposed to lots of different units. In the do nothing scenario, we have said, well, it is actually do something, because the do something is we would have to build a new facility for part of St Helier in the kind of like the comparator case we are using, because we just can't carry on. You heard this morning about everyone's visits around the place. The functional layout is simply atrocious for vast quantities of the clinical services on this site. So in the do nothing, or the keep going with the acute services on 2 sites, we have included the capital of building a small extra new block on this site. We are not going to do that at Epsom. And you would continue in the scenario of running 2 acute services, aim to keep acute services at both Epsom and St Helier. And the reason why you end up with such a large deficit is because we don't reduce the amount of agency staff that we use, and you incur the extra cost of servicing a new building on this site.
Thank you. Oh, Dave, you're standing up. I'll give this final question, and then we are going to move on.
Thank you very much for that. Daniel, you'll recall that you granted us an audience with you before you even took over here, and you know that we've been on your case ever since. This whole exercise has been the most mendacious thing I have ever seen. You start off by saying we're only going to consider 3 scenarios. You do not consider the scenario of doing what we've asked you to do and you said you would do and have failed to do, i.e. produce a costing for bringing up to standard Epsom and St Helier hospitals. You have not done that exercise. You have simply conveniently eliminated it from all consideration. You have threatened people, as the first questioner pointed out, sign up or you lose both hospitals, which is appalling and disgraceful. We know where you're coming from. We know what happened to Northwick Park as a result of your A&E closures in northwest London. We know that you started off at PricewaterhouseCoopers, who are deeply into all of this. We heard Charlotte Hall say we can't possibly have consultant-led maternity on 2 sites because we'd never make any money. She actually said that at your first engagements presentation. This whole exercise is utterly disreputable, and I hope everybody here will make sure that they make everybody in the community aware of this and rise up and prevent this travesty.
Right. Thanks for that, Dave. We're now going to move to the next step, but before we do that, obviously the board needs to endorse and approve the engagement or not. I'm going to ask them to make that decision. Just to be clear, what that means is the next step, if you approve it, the next step is that this is submitted to the system in its various forms. It goes to NHSI, it goes to NHSE, it goes into the STP process, it goes to Surrey Heartlands, it goes to South West London, it goes to the clinical commissioning groups and to the local authorities. So it goes a long way beyond here, and in many ways, the decision on the future is not entirely, in fact, is not ours. The decision becomes a system decision to take what we have done, input it into all the other work that they are doing, and there is a lot of other work going on for the system, and then decide how to move forward. We've put up a timetable, which is one of the ways forward, which could happen, but we are, we can't guarantee that that timetable is going to be the timetable that happens. So I need to be clear about that. So, of course you can, Pat.
I would just like to say, in response to some of the really rather strong criticisms you've made of the process, and so do I have sat on this board as a non-executive for 6 years, and I can assure you that I have absolutely no interest in anything other than seeing the best the best services provided to the people of this area, of which I am one. I am totally committed to the NHS, as I believe everybody sitting around this table is, but I can't speak for them, but I believe so, having worked with them so long. And I'm an independent person on this board, and I would ask you to respect the fact that while we may differ in our views, we have integrity in sitting here trying to achieve that. Thank you.
Thank you very much, Pat. And I would now ask the board to say I will invite them to approve this document. And
so Lawrence, I was just going to make that explicit. So it's all of the recommendations that are set out on page 57 of the strategic outline case neatly summarises all of the points that we as a board need to approve, including setting out what we will do to support the rest of the system to progress all of the work we've set out. So those are the things I want the board to explicitly approve.
thank you, Peter. So it is page 57, chapter 10. So I'm not going to read them all out because it would take too long, but it's quite clear that what we are doing is we are asking your agreement to submit and push up into the system the strategic outline case. That's it in a nutshell. So do I have agreement? I'm getting lots of nods. So
you certainly do. You have.
No, I have agreement. And is there anybody who does not agree? Right, thank you very much. So we will now take that forward. Thank you very much. No, there weren't any abstentions. Sandra, we're going to continue with the board meeting now. Thanks very much. We're going to... We are aware that... Right, thank you. We're going to stop now. We're stopping this discussion. We're moving on to the next point, the next item, which is item 4. And I'm going to ask the team to take us through the integrated performance report. Thank you very much.
Thank you very much, Chair. So I think that if I start on 1.1, you will see that the themes that we discussed at the last board meeting broadly have continued over the course of the last month. Our HSMR remains favourable, with no differential split between weekday and weekend HSMR. I think the points I would like to highlight in terms of 1.2 are themes that we've discussed previously. We are continuing to have capacity issues with our stroke patients, particularly on the Epsom site. And as we have discussed previously, we are in the middle of having further discussions about the capacity that's really needed in order to continue the acute stroke model on that site. In terms of our compliance with VTE and dementia, these metrics are linked. And we had a very good conversation at the Board Quality Subcommittee, the last meeting around this. We really strongly believe that the new whiteboards that are being rolled out across the hospital will significantly aid compliance and completion with these metrics. And I think in terms of dementia, it's also important to note that we have strengthened our older people's team since the board last met quite significantly, and that will be a significant driver to enhance performance. So I'll now hand over to Charlotte to go through the safer staffing metrics.
Thank you, Ruth. So from the safer staffing perspective, we have seen 2 months worth of a net increase in our nurses and midwives that have come into post, which is very good to see. The supervisory status is around 50%. That means 50% of the time for the ward managers is spent in the numbers, 50% is spent supervising care. Moving on to infection control, we didn't have any MRSA bacteremias in September. Our main problem over the August-September time has been the cluster of CPE, which we have on 2 wards at the moment, and we've instigated screening for all patients and hydrogen peroxide vapour cleaning when the patients have gone home. Maternity care has got maintained its standards with its green indicators. There's been a slight reduction in the number of babies being born through the birth centre at Epsom, but that's because we've had a blip in their staffing of midwives, and that's now gone back up to normal numbers.
Thank you, Charlotte. On the patient experience, I'd like to draw the board's attention to a couple of things on the report, if I may. The first is in terms of the response rate to the friends and family test. The board will be aware that we have struggled for a period of time to increase the numbers of people completing the friends and family test. We have put back in the paper format. We went kind of electronic, and you need a combined approach. So we have now developed a much more sophisticated approach to capturing people's information and people's feedback, and you'll see in there the response rate has improved, and we are continuing to maintain that response rate. We do see a blip in maternity, but we think that's a blip and we are investigating that because maternity is more of a complex area in terms of how you gain feedback, because you gain feedback on multiple occasions during a woman's care with us. So that's not just like a one-off as you get with A&E. The other thing to report back, and I know the board's been very keen to continue to get feedback on, is our complaints. We are continuing to show steady improvement in terms of our responses, and that is the time agreed with the complainant to respond to their complaint. We don't do them all within a specific time frame because that is agreed, because some of them are more complex, and we are starting to see a sustained improvement on there. It's not a massive improvement, so this gives, I hope, the board confidence that we are on a strong upward trajectory, which is really important on that. The other thing that the report doesn't say, which is really positive on the complaints front, is we are a long way down now redesigning the complaints process, which has something been done with not just the complaints team, but has been done with members of staff within the divisions, who doctors and nurses who answer the complaints and work with us on the complaints process. But most importantly, with complainants, they have been very, and I'd like to thank them for their input in terms of helping us to redesign the complaints process. This, we hope, will be able to continuing with our stronger performance in terms of meeting the complainants' needs. Thank you, Chair.
In terms of cancer access, the Trust has continued its strong performance in meeting the standard across all of the metrics except the consultant referral standard, largely due to very low volumes, which makes it difficult when you have one-off individual cases. The point I would highlight, though, is the large volume of increases in cancer referrals that the Trust has been receiving. The report refers to a 45% increase since April and a 17% year-on-year increase since this time last year. And that's just something we're attempting to make sure we don't lose sight of. But at the moment, we're holding our position.
Is that because just there's a general increase, or is it because other places aren't able to deal with them, and so they're coming to us instead?
So the 2-week wait referral increases are due to several reasons. First of all, some of the GPs have got altered pathways and therefore they're referring for cancer, whereas in the past they may have made a routine referral. So you might see that within a specialty the overall volumes remain broadly consistent, but the proportion of 2-week waits increases. So that's the first reason. And the second part is sadly due to the fact that cancer is often a degree of ageing, and as we have an older population, we'd expect to see more 2-week wait referrals.
So does that mean St George's are back able to do the operations?
I can't answer that one.
Customers from St George's, can we?
I'm afraid I can't answer that question. I'd have to go and have a look at.
So sorry, not the last board meeting, the board meeting before.
So you're right, Bob. So we have a lot of joint appointments between us and St George's, and quite a lot of those joint appointments are bringing patients to us so that they can get treated in a more timely basis than they would do at the hospital that has longer waiting times. And we think that's entirely appropriate for those patients, and we're supporting that to happen.
No, it's okay. I'm just clarifying the scene for you. But I wonder, could some of these people go to Epsom instead of go to St George's? I mean, to St Helier. Do they all have to go to St Helier?
So lots of them do. So when we talk about cancer services, it's across the Trust. It isn't St Helier only.
In terms of the 18-week referral to treatment standard, the Trust position was 89.1% last month, which is a very small improvement on the month before. There's some key troubled specialties such as orthopaedics, urology, cardiology and ophthalmology are the ones I'd pick out with high volumes of backlog waiters, in large part often due to staffing issues. What are we doing about those things? Particularly for orthopaedics, we're now largely fully staffed in terms of some of the shortages we were reporting previously, and it's now expected we'll be able to churn through the backlog. And in parallel with that, we're doing a large piece of work in terms of examining our actual capacity to deliver the standard against our current workforce and work out whether we can shift some of the work to different grades of staff, or whether we actually need to be doing all of the activity that we're doing in terms of the numbers of follow-ups, which will create capacity to see new patients. And I expect to be able to report on that at the next board report. We're making the diagnostic waiting time standard, which is good given some of the complexity of the work that we're doing here, and our elective length of stay remains broadly constant. Just moving on to emergency access, the Trust has continued its strong performance throughout the year, for September reporting just over 95%, which is really encouraging, and our length of stay has remained broadly consistent as well, which is good. Our delayed transfers of care have fallen back from the August board, which again has eased some of the pressures on the hospital and has allowed us to maintain our performance.
I'll take just for time, I'll take the first page together really, vacancies, staffing levels and agency and turnover. So there's a slight reduction in the vacancies, and you can see the staff groups there, particularly allied health professionals. We've still got vacancies in the States, but you can also see that we maintain our clinical workforce over the last year, apart from those times where it's a changeover of the junior doctors, which is that technical issue that we're going to fix at the end of the year, but it's broadly consistent. The areas addressing these, our actions are still to maintain the focus on recruitment, as well as work on retention, to try and fill as many posts as possible with permanent staff, as well as daily managing of the rotas to make sure all staff areas are safe, that Charlotte mentioned earlier. The second page, two areas of concern are the sickness absence and the training. So we've got our Autumn 4 campaign, which is focusing on statutory mandatory training, to get that up by the end of the calendar year, and still doing work to manage absence. And we've seen a bit of a rise in surgery again as a reason, so we're giving some focus to that because that's planned care. And also just some news that's not on there about the flu vaccinations, which is part of our Autumn 4, where we're up to 70%, which is much better than we've had in previous years at this stage. And also a staff survey, which again is not reported here, but is part of the Autumn 4. We're currently on 41% of staff have completed the staff survey, which is much better than this time last year, but we're still pushing hard in the last 2 to 3 weeks of the month to get over 60% of the staff completing the staff survey.
How is the South West London Staff Bank?
That's now likely to be January because of the technical issues, and we're not willing to put this in just before Christmas because it's too high risk to have this in at Christmas time. So we're doing that in the new year.
Yeah, that's disappointing, isn't it?
Is.
I mean, you know, because this has been going on for a long time, and we were assured that it was all going to be. I mean, what is the problem?
It's they Allocate, which is the software provider, had just not worked through the amount of traffic that would be in the system from having all 4 populations of people that could be working in the temporary staffing posts accessing a system at the same time, and they've just not been able to get a solution in, which is also very disappointing because I'd have expected that they would have known our staffing numbers and the amount of temporary staffing traffic that therefore would generate, but we've been testing it and we're not comfortable that when we do the testing that it's robust enough to not go wrong.
Do they have a plan, which you've seen? Have they shared their plan to fix this?
They have got a plan, but it's reliant on that robust testing that we're doing. So, I mean, Daniel's been close to this as well.
But let's just be clear, this is a NHS first. No one else has worked out how to share a staff bank across 4 organisations electronically in the way we are proposing. So it's not completely surprising that there are some technical difficulties. And we're not paying for any of this because this was an agreement with Allocate that we would go first to make it proof of concept so that when it worked, the rest of the NHS could use it. So it's disappointing that there's some technical things, but it's not completely unexpected, I think.
Just one thing, Chairman, to highlight on the report in terms of our website. Continues to be a very popular site for people to visit, and again the main theme search is on jobs, so we continue to work very closely with HR colleagues to push the opportunities that we have within the organisation to come and join us.
Thank you. We have 5 financial indicators that we monitor, and you see on the board report there. At the mid-year point for our income and expenditure accounts, we are just over £200,000 ahead of target, and currently as we sit here we're still forecast to deliver our control total of an £18.8 million deficit as agreed with our regulators, NHS Improvement. Part of the reason we're on targets is because our cost improvement programme, as at month 6, we've delivered £300,000 more than we were planning to do over the first 6 months. But board will acknowledge that over the coming 6 months, the target gets higher and more difficult to achieve, and the divisional teams are working trying to achieve that additional target. Capital expenditure, as we've talked about in previous board meetings, we're behind the initial plan, but we are still forecast to spend the money that was allocated to us, and we've discussed earlier. And that will obviously have an impact on the cash holdings. So the cash holdings currently at 16.8 million are higher than forecast, and that's predicated partly on the reduced capital expenditure, but as the capital expenditure accelerates, the cash will go down in an equal and opposite way. And we maintain, compared to other trusts, our payment policy at 89% is much higher than other trusts in the sector and around London.
Thank you, Rakesh. Before we move on to the corporate risk register, are there any points that any of the non-exec chairs of any of the committees would like to raise at this point on performance? You okay? Good. In that case, Peter, thank you.
Thank you, Lawrence. So the at this month's Performance Assurance and Risk Committee, we covered off, I think, 5 main components. The first one was the performance assurance part of that committee, which Pat very helpfully chaired in Ian's inability to be there on that occasion, where we had a deep dive around the RTT performance, which was Dan spoke of in the previous part of the meeting. So I think it's important that you, on behalf of the board, that deep scrutiny was undertaken, and the plan will be to do that every month going forward until those plans are back on track. So that's the first point, is around the performance assurance and the RTT. The second point is that because it's really the end of Q2, we've reviewed all of the risks in the corporate risk register. So we're satisfied that all of those risks that were there needed to be there and had the right kind of mitigations in place. What that led to was a change in the financial risk score, reflecting what Rakesh has just said around the scale of challenge ahead in the second part of the year is increasing. So we feel that risk needed to be elevated to reflect that. So that's those elements. The other part of the work that we did reflecting that review was to identify 2 new significant risks, which are really a pulling together of related themes. The first one is about how pressured staff feel to be working in the organisation at the moment, particularly over recent months, about the level of activity, both through A&E and under wards. And that's the first risk that you see in Figure 1. The second risk, which is also related to pressure, is to say actually, and as Elizabeth and I saw on the stroke ward this morning, then there are a number of outliers not in quite the right bed for all of their stay, and we need to do better at that. That's partly driven through the volumes through the door and needing to care for people. So we feel that actually we aren't providing the best possible care to every patient for every moment of their stay, and therefore we've identify there are further actions we need to do to review, for example, what are our escalation areas, how we use them, how we staff them, to ensure we can provide, within the constraints of the real estate, the best possible care we can for those patients who come through. So those are 2 new significant risks that we've added to the risk register, and just to bring those to the board's attention. Thank you.
Thank you very much, Peter. Pat, Elizabeth, Aruna, have you got anything from a Park Committee perspective or discussion?
Risks are turning over and new risks coming on, and risks appropriately coming off. So I think it's functioning as a dynamic tool.
As an aside to that, and something that Peter and I spent some time working on a couple of weeks ago, Lawrence, was that he and I have had a detailed conversation about cybersecurity risk, and we will be bringing forward some specific monitoring processes around that.
Thank you very much, Elizabeth. I know that you took that on after we and all other trusts had a letter, didn't we, from NHSI about cybersecurity.
Yes, and my initial review is that the trust is actually very well ahead of the curve, and it's a very good team in place.
Thank you. Peter, it's you next again on update of corporate objectives.
Yeah, so I'll start this conversation, although clearly this is a team effort. It encompasses all the 25 priorities that the board agreed that we set ourselves for the year. So there's 2 ways of viewing the summary. The first one is kind of performance to date, which is summarised in the first couple of pictures. What that says is that by the end of Q2, we're delivering what we said we'd do in 15 out of those 25. We're slightly off beam on a further 7, and 3 are kind of in the amber to amber red and red space. We'll come on to cover the specifics of those in a moment, but that's sort of the headline element, which I think reflects the fact that Q1 was easier to deliver because the plans were about ensuring there was a robust plan in place, and as we now start to deliver those plans, some of the challenges, as indeed, for example, the corporate risk register reflects, we have an awful lot to achieve, but we have a finite amount of capacity, whether that's people or money or skills, to be able to achieve those. So that's partly reflects, I think, the drift into more the amber green and amber space. The significant changes are in the looking forward, which is on the next page, which is the about how do we then look towards the year end. What that says is that we think at this stage we think we should deliver around half of our targets, not necessarily comfortably, but we've got a high degree of confidence that we'll be able to deliver those. There are some more in the middle, which are reflecting the scale of challenge. The two that are either amber red or red are around, so our money position has changed from what was kind of one of the ones that's changed because, as we said, the second half of the year is harder to deliver. The other element is around our staffing, which again reflects what we've heard in the performance report and in the risk register. And then the third element, which is red, which is sort of disappointing to say, but at this stage, we do not believe we will be able to achieve the RTT target for the year overall, but we are making progress on a recovery plan, but we won't be able to achieve the 92% for all of our patients by year end. So that's kind of the summary element.
Peter, can I just ask a technical question? Is the 2-week cancer target included in the overall RTT, or are they completely separate?
So they're reported separately, but 2-week wait patients are on pathways that are counted within RTT.
Yeah. So in our so we have 3 priorities around. So we have 1 for cancer, 1 for A&E, and non-elective admissions, and 1 for the RTT pathway. So those 3 are scored separately in setting priorities and how we've evaluated those. But and we report all of a whole heap of metrics nationally against all of those individual components. So it's not we haven't sort of lost cancer amongst RTT. It's clearly a separate priority.
Fine, thank you very much. Any other points on the corporate priorities report? Good, thank you very much. That is the end of the meeting. Thank you very much for coming. And we'll see you again in December. Oh, Bess, sorry. You can ask 2 things, yes, of course, as long as they're not about the strategic. Okay. Something's been renamed.
So I'm not aware of that, Beth, but we do continually update the directory and the maps, and we're looking into that to see what that may be.
I think that's a really good point, and I'll pick that up with the volunteers because we can work with the states and we can put a map and an updated list to you. I think that's a really good idea. Thank you, Bess.
The second one is, why can't we get any replies to our emails?
Oh.
Our chairman sent one to Lawrence and he's still waiting for a reply.
I thought that was all dealt with. I thought that had been replied to, Bess. I'm sorry. I saw that and I asked for it to be replied to, and I handed it on. And Trevor?
So I'm aware of some issues, etc. And Beth, we have communicated around meeting. I know we just haven't set out that date yet, but we have discussed about meeting up again with Peter to go through some of the issues and some of the around management of that, and then reset so we can continue to receive the support that you provide.
Thank you, Bess. Thank you, everyone. Thank you very much for coming, and we'll see you next time.